These are my disclosures. And to start, the takeoff atrial fibrillation is the most common cardiac arrhythmia in men, and it has a very high prevalence in the world, but particularly in Asia and in China. It is associated with ischemic stroke, with heart failure, with mortality, and stroke and cardiovascular complications can be mitigated by the use of oral anticoagulations, and all the guidelines advise that patients with risk factors should receive oral anticoagulation, taking into consideration that on the one hand, the reduction of stroke comes, on the other hand, with an increase of major bleedings. However, recent data have challenged the estimation of the stroke risk in patients with atrial high rate episodes on their pacemakers or ICDs or subclinical AF detected by wearables. And we all wear eye watches and patches and things, Fitbits when we work out. So every bit of atrial fibrillation that would have gone unnoticed previously is now detected and sometimes urges for intervention. We estimate the stroke risk historically by the CHATS-VAS score. In the recent European guidelines, female sex has been taken out of the equation, but we test and we try to find the risk by applying the score, testing and checking the risk factors. And as you can see from these old data, there is a pretty linear relationship with the annual stroke risk and the CHATS-VAS score in patients not being anticoagulated. And if you then apply anticoagulation, you've reduced that risk by 65 to 70%. Historically, this must be done by vitamin K antagonists, but since the emerge of the DOACs, the direct anticoagulants, it has been clear that from the 4 large phase 3 trials, the efficacy is on average non-inferior or superior to the use of warfarin, with a combined risk reduction of 19%, which was very significant. And if you look at the bleeding side, you see more or less the same. This just did not reach statistical significance, but taken together, there's a 14% numerical reduction in bleeding. So NOACs are the first choice for patients with atrial fibrillation. But now let's have a look at this. This is the ASSERT trial from Jeff Healy, 2012, where they investigated 2,500 patients with pacemakers without known AF, and all these patients had a lead in the right atrium that was able to 24/7 detect atrial high rate episodes. And the main findings in this study, where there was a follow-up of 2.5 years, is that once there are subclinical atrial tachyarrhythmias, once there are atrial high rates or subclinical AF or whatever you want to call it, rapid rates of a few seconds in the atrial pacemaker lead, the risk of developing clinical AF is considerable. It's about 20%. And if these subclinical atrial tachyarrhythmias are absent, the risk is a lot lower. And similarly, although the numbers are low, the detection of atrial high rate episodes of subclinical AF was associated with more stroke and systemic embolism in this group than when these subclinical arrhythmias were absent. So this urged to think about, can we use these means of detection for clinical decision making? And this is a paper that I like very much. It's a paper that is quoted in the guidelines from the European Society, but it's written by Rachel Kaplan in Chicago. And what they did is they used a very large database of patients with an ICD, and they looked at whether the detection of atrial high rates predicted the development of more atrial arrhythmias. And this indeed is the case. So if you detect 5 minutes to 1 hour, you have a 5% chance to go up to 24 hours. And if you detect 12 hours, you have a 70% chance, 63%, excuse me, to develop into more clinical AF. So The detection of these atrial high rate episodes are a marker of progression of disease, and indeed, they are associated with the occurrence of stroke. Here you see um, the duration of the atrial high rate episode. Here you see the CHA2DS2-VASc score, and you see that the more high rate episodes you find, the higher the risk of stroke is. But what you can also appreciate is that if you have no AF, that the higher the number of risk factors for stroke, the higher the risk of stroke. And this may seem very obvious, but it seems that the CHA2DS2-VASc score is a more important determinant here for the risk of stroke than the duration or the presence of these atrial high rate episodes in this study, this retrospective study from the Medtronic registry. So how about wearables? This is from the Loop study in Sweden, where they included 7,000 patients, 6,000, excuse me, who were at least 70 years of age with at least one additional stroke factor. And these patients were randomized 3-1 to the implantation of an implantable loop recorder or standard of care. And in case of detection of atrial fibrillation, oral anticoagulation was instituted. And the results are somewhat disappointing, as there was no reduction in stroke. There was no reduction in a composite endpoint, including stroke, systemic embolism, or transient ischemic attacks. And there was no effect on mortality. So now we implanted 1,500 patients with an ILR. We monitored them very well. We did the best we could to prevent their strokes. And what we find is that there is no effect on mortality. So the next step is, should we anticoagulate these patients? And there are two big trials that were published 2 years ago. The NOAA AFNet trial that included patients with at least 6 minutes of atrial high rates on their pacemaker and who were at least 65 years and with one additional risk factor. And they were randomized to either placebo, and placebo was no anticoagulation unless there was an indication for antiplatelets, in which case the patient received aspirin, or anticoagulation with edoxaban reduced to 30 milligrams in case of dose reduction criteria, and a dummy for aspirin if there was a need for that. And these are the baseline characteristics of the trial. And I just want you to pay attention to the age of the patients, almost 78 years, to the mean CHA2DS2-VASc score, median, which was 4, and to the about 50% of the patient was using aspirin. And the median duration, so this was not 2 or 3 minutes, the median duration was almost 3 hours of the atrial high rate episodes. And when then the patients were randomized to edoxaban or placebo, there was no effect on the primary outcome. And the study was terminated early because of this, but also because there was a significant increase in the amount of major bleeding, which of course makes sense. If you prescribe an anticoagulant and compare that to placebo, you will get more major bleedings, but no effect and more major bleedings. The other study is the Artesia study that basically looked at the same thing. It's larger, it's about 4,000 patients, and it excluded patients with episodes longer than 24 hours on the ECD. They should have risk factors and they should not be on anticoagulation. But here, the randomization was apixaban or aspirin. So there was some kind of anticoagulation anyway. And the main findings here, first the baseline characteristics again. These were old patients, 77 years of age, with a mean CHA2DS2-VASc score of almost 4. And these were the results. Apixaban resulted in a reduction of stroke compared to aspirin, and no effect here on bleeding. But look at the rate of stroke here. If you allow me, the annual rate of stroke in the apixaban arm was less than 0.8% per year. And I'll come back to that. That is extremely low. So there is a differential effect here. Apixaban seems to be better than aspirin, but the absolute rates of stroke, also in the aspirin arm, are extremely low for a patient population with a CHEST-VAS score of 4. And then the Factor 11 trial came in. The first Factor 11 trial is the Oceanic AF trial that tested asundexian versus apixaban, and that was terminated because of this effect here. This is stroke, and it's clear that apixaban is far more efficacious than asundexian, and therefore the study was terminated. But again, look at the absolute stroke rate in patients with a CHEST-VAS score of 4, 1% per year in the apixaban arm. So I thought, let's go back to the initial phase 3 trials and let's have a look at what the stroke rates are in these trials. And in the Aristotle trial, testing apixaban, the annual stroke rate was 1.27%. But remember, this is a different patient population. These patients had a far lower CHEST-VAS score. This is what we think the rate of stroke is with a given CHEST-2 or a given CHEST-VAS score. And this is what we base our judgment on with respect to starting anticoagulation or not. In my opinion, everybody should have anticoagulation unless there is a reason not to anticoagulate because the risk is very, very low. But in patients with device-detected AF, the risk of stroke is far lower than what would have been expected from the CHEST-VAS score. So we should reconsider here, are we looking at better treating patients? Are we looking at a different disease? Is device-detected AF something different than clinical AF? Or is our concomitant treatment, our treatment of comorbidities, becoming much better? This is the summary here of the raw data from the Aristotle trial, 2011, with a mean CHEST-VAS score of 9, annual stroke rate 1.27, which is 39% of what have been predicted from the CHEST-VAS score. In Artesia, with a mean CHEST-VAS score of 3.9, the annual stroke rate was 0.78, which is less than 20% of what have been predicted based on the CHEST-VAS score. And similarly, in the Oceanic AF, it was 25% of what have been projected or estimated. So it seems that apixaban has become better. It's like wine. If you leave it for a while in your cellar, it becomes better. Well, that's of course not the case. That's of course not possible. And the fact that, if you go back here, the fact that the stroke rate in the asundexian arm was very high, argues against the fact that the disease has changed. So I think that the efficacy of DOACs have become better in the context of a better treatment of the disease. So this brings me to my conclusions. AF is associated with stroke, and stroke risk factors can estimate stroke risk. And that's what we use the CHEST-VAS score for. There is a relation between device-detected AF and progression to clinical AF. It's not the same. There's an association. There's also a relation between the CHEST-VAS score and stroke, which is irrespective of the presence of device-detected AF. Also, without detected AF on your ICD or pacemaker, if you have a high CHEST-VAS score, your risk of stroke is higher. Once AF is detected on a device, it's associated with a much lower risk of stroke than expected based on the CHEST-VAS score. And population screening in high risk population so far have resulted only in more AF detected, but no effect on clinical outcomes. And that also accounts for the recently published Amalfi trial. Contemporary Oceanic AF study in patients with clinical AF, extremely low stroke rates with apixaban, whereas the use of asundexian argues against that the disease of AF has changed. Even if you consider asundexian a placebo, the stroke rate in apixaban-treated patients is extremely low. This is what I wanted to share with you. It seems to be that DOACs have become more effective than at the time of their introduction. This may be due to better treatment of heart failure, of hypertension, of atherosclerotic complications that all contribute to stroke risk. But it's still very important to estimate the risk, but it's also important to estimate the risk in patients who have no symptoms and no clinical AF. Their baseline risk of getting a stroke is a lot lower, so the balance between bleeding and stroke prevention may be different in those patients. Thank you for your attention.